So we're going to change tack completely now and talk about mistakes in contemporary practice and mistakes in congenital heart disease. And the reason we talk about this is because there's now an estimated 1.5 million adults in North America with congenital heart disease because of the success of cardiac surgery largely. And it's a population that's growing rapidly, and I know you see some of them in your practice. And unfortunately, pretty much every week we see mistakes not only in their diagnosis but also in their management, which is why we bring it up at this conference. So I'm going to look at 4 areas fairly quickly where we continue to see many mistakes in practice. Cyanotic heart disease. Also the fact that very often in adults we don't even think perhaps that they could have congenital heart disease. How can you get to 50 or 60 with congenital heart disease, be examined regularly and completely miss the diagnosis? There are those patients who've had prior surgery when perhaps cardiologists are unfamiliar with the consequences of the surgery that the patients have had. And then lastly, late referral, which unfortunately is still a major problem. So I'm going to begin with this topic, Eisenmenger syndrome, and we've touched on it a little bit in the MOC session. Many of you know that these are patients that begin life with a large left to right shunt, often a ventricular septal defect, but they end up with pulmonary vascular disease, right to left shunting, and of course then they are blue. So we'll take some cases, some of them will shout out, some of them will have an audience response system, but these are fairly typical. And again, there aren't many of these patients, but unfortunately, they're not the same as your routine patients. Mistakes that you make in practice are life-threatening for patients with cyanotic heart disease. So here's a woman who's admitted with pneumonia. She's blue, she's on IV antibiotics. 20 minutes later, she has a speech disturbance and right upper extremity weakness. What's the diagnosis? Air, yes. So for these patients, you need air filters on all your IV lines because one little bubble may cross over, go to the head, and give them a stroke. Here's one who was just admitted before I left, and she's still in our coronary care unit, a 55-year-old woman, Eisenmenger AV canal, admitted with pneumonia. She's on Coumadin for atrial fibrillation. She gets, of course, treated with antibiotics. In 3 days, her INR is above 6, and now, of course, she has hemoptysis, even in our own institution. So these patients, of course, are very challenging, and when you have hemoptysis in Eisenmenger syndrome, this can be life-threatening and indeed can be a cause of death for many. So let's take a case. Here's a 40-year-old admitted with 3 days of hemoptysis, Eisenmenger VSD. The chest x-ray also shows an infiltrate. The labs there, as you see, the hemoglobin, of course, is high. Which of the following is true? You should do an urgent bronchoscopy, should do a CT scan, should be anticoagulated with unfractionated heparin, should have a therapeutic phlebotomy. Please vote. Okay, so most people think you should have a CT scan, but a number think you should have bronchoscopy or heparin, and still 13% want to bleed this person. So the message still isn't getting through. So these patients often, you see this huge pulmonary artery, they do get pulmonary thrombi if you do a CT scan, and you can see a big one here in this aneurysmal pulmonary artery. But if you have a patient admitted with hemoptysis, you do not anticoagulate. These patients are at major risk of bleeding. You do not routinely anticoagulate a patient with Eisenmenger syndrome and hemoptysis. And the problem is that many of these patients will actually die with intrapulmonary hemorrhage. Anticoagulation may kill them. That's a really important mistake. Do not routinely do it. Intrapulmonary hemorrhage is catastrophic. Next teaching point, you do not do a bronchoscopy. You bar the door from your friendly pulmonologist with the bronchoscopy. You do not need to do it. Why? Because you can see the infiltrate in the left lung. You know where the blood is coming from, and almost certainly that's hemorrhage. If you do a bronchoscopy, the only thing they'll tell you is where the blood is coming from, and chances are the patient may destabilize, drop their blood pressure, drop their oxygen. So bar the door from your friendly pulmonologist. Here's another one, another mistake. Another Eisenmenger admitted with right upper quadrant belly pain. They're on diuretics, they're tachycardic, they're dehydrated, and again, the hemoglobin is high. So we think there's a gallbladder problem. What do? We do a CT scan. 6 hours later, the urine output is going down. Renal failure. Why did these patients get renal failure? The creatinine wasn't that high, right? Of course they get gallstones. This was gallstones because they have heme breakdown, lots of pigment stones. But blue patients, cyanotic patients, have very abnormal kidneys. Even if the creatinine is running about 1.4 or 1.5, the kidneys are very vulnerable to failure. And if you give them contrast or non-steroidals or gentamicin, or they go to the cath lab, the kidneys may shut down. You have to give these patients lots of fluid, limited contrast, meticulous monitoring of their kidney function, intake and output, or you will lose your patient. Something that's routine for you and I, for the cyanotic patient, unfortunately, may be the end. So kidney function too. Do your CT scans if you need to, like for the patient with the infiltrate in the lung. It may help you. Typically it won't. They'll say pneumonia, maybe a bleed, maybe something. Doesn't get you very far, but always monitor the kidney output when you're using CTs. Here's another one. 2 episodes of right-sided numbness, the hemoglobin you see, otherwise doing fairly well. Does this person need to see you? Is this important? Little numbness in the fingers, what do? Do you admit them for heparin therapy? She's quite blue, you saw how high the hemoglobin was. Do you do a therapeutic phlebotomy? We're suspecting a stroke. Do we do an MRI of the head? Or do we reassure since the symptoms went away and only lasted for 5 minutes? Nothing necessary to do. So a 5-minute neurological disturbance, what to do? Please vote.
All my friends know the low rider. The low rider is a little high.
Okay, so 66% got it right. Anytime you have a neurological disturbance in a cyanotic patient, scan the head. Now, those of you that want to do a phlebotomy, you're worried because the patient's got a high hemoglobin, and you think there's sludging going on, and you're worried that that was the explanation for the neurological disturbance. In fact, you rule out endocarditis because something could be going up there to the head, so you do blood cultures and echo. You scan the head. Any neurological disturbance. This could be endocarditis, it could be an aneurysm, it could be an abscess. These patients are vulnerable to abscess in the head. Do not assume that this is sludging from the high hemoglobin. This person actually had an aneurysm in the head and required surgery. So those of you that want to phlebotomize your patient, like this poor painting here, do not do it. This is a very important message. Cyanotic patients need the high hemoglobin to carry the oxygen around. If the hemoglobin is 19 or 20, 21, and the patient feels okay, leave them alone. Their risk of stroke is way lower than you think. Their risk of stroke is way lower than you think. Do not phlebotomize them. Do not destabilize the hemopoiesis because you will make them worse. If you make them iron deficient, tiny red cells, microcytes, are not deformable. They don't go through the cerebral circulation, and you increase the risk of stroke. Do not bleed them. Do not make them iron deficient. Leave the hemoglobin alone. Their risk of stroke is very, very low. Okay, so for all of these things, basically, these patients need special care, and I'd encourage you to follow along with a local congenital heart disease center, because really that's what these patients need to avoid catastrophe. And they can live to their 60s and 70s now with a really fairly good quality of life. So we've done a lot to change their prognosis. So let's move ahead and think about, not even thinking about, the diagnosis of congenital heart disease. How many of you here read echoes? Most of you, all of you. Okay, so I'd like you to be thinking about the clinical exam, which of course is a dying art, and how the clinical exam needs to be consistent with the echocardiogram. And sometimes we may assume that who tells us an echo report has got it right. So here's a case I've been following for the last few months. This was a 29-year-old referred from an obstetrician. She's 25 weeks pregnant, and she had pulmonary stenosis diagnosed at 4 years of age, confirmed on echo. She's been active. The heart murmur's been heard over the years, and she hasn't had any other evaluation, and now she's pregnant and well into the pregnancy. And here's her clinical exam. So she's in sinus, she's got a normal JVP, the carotid's normal, the blood pressure's normal. Supposed to have pulmonary stenosis. So on exam, the RV feels normal. She's got an ejection click at the lower left sternal border with a soft systolic murmur, which I can hear at the back. And the second sound is normal. So she's supposed to have pulmonary stenosis, and yet P2 is easily audible. That is not consistent with pulmonary stenosis. It should be quiet if she's got pulmonary stenosis. So the alarm bells are already going off. Here's a echocardiogram. So you all read these, just take a look at this. The echo has now been repeated because I'm not convinced she's got pulmonary stenosis. That short axis, you can see the pulmonary valve, and just be thinking about this as we look at this, and anybody can shout out if they like as we go through this short axis. Let's move ahead. Again, we're looking at the pulmonary valve. Looks pretty darn good, doesn't it? And here's the pulmonary velocity, 1 meter a second. Pulmonary stenosis. Here's the tricuspid regurgitation. The TR velocity is 2.3. She's got normal right ventricular pressure. Pulmonary stenosis. Keep your thinking caps on. Here's the long axis. Anybody want to shout out? Bicuspid aortic valve, and look at the aorta, 4.5 centimeters. Maybe that's why she has a click. And here's the aortic valve, and you can see there's a little bit of regurgitation, and there's the aortic velocity, 2 meters a second. And we're looking at subcostal, so we make sure her aorta's all right down here, and her inferior vena cava. You can see the aortic velocity in the bottom box. And we'll move ahead and keep looking, and her ventricular function's good. And you can see that bicuspid valve, and the perfectly happy pulmonary valve we can see from subcostal. So your diagnosis is bicuspid aortic valve with aortopathy. Anything else you'd like on the echo? Anything else you'd like on the physical exam? Did I tell you everything? Femoral pulses. Thank God somebody out there wants to feel her femoral pulses. And look at this echo. This is the abdominal aorta, and I showed you this. This is the diagnosis. This is not what abdominal flow should look like in an aorta. It should look like that, with a brisk upstroke. Hers looks like this, like a wiggly worm, and that's because there's no blood getting to her aorta. And if you look at the suprasternal window, you can see that she actually does have severe coarctation, with a ridge there. And there's the velocity, which is probably suboptimal. So this person had never had the femoral pulses palpated, and I couldn't even feel them. So she has a bicuspid valve with a 4.5 centimeter aorta and a severe coarctation. The exam was not consistent with pulmonary stenosis. Nobody checked, and the femorals were impalpable. Many of our fellows never take the trousers off our patients to feel femoral pulses. You've got to be thinking about these diagnoses in these patients. On Monday, we delivered a baby boy by C-section, Happily, he grew well, but I was very worried about the baby and her through the pregnancy. And here you see her imaging. She has severe coarctation. She's got dilatation of this aorta, and now she's going to be heading for surgery in the next few weeks. So I show this case to remind you how the echo, you can't assume that even the echo gets it right, and make sure it's consistent with your physical exam. What about those patients who've had prior surgery? This is the huge bulk of our population that we see. This is a common disease, tetralogy of Fallot. I remind you, a common cause of cyanotic heart disease. And you all know that when we repair tetralogy, which we've been doing since the 50s, we close the VSD and the surgeon resects the pulmonary stenosis and often patches the right ventricular outflow tract all the way up to the pulmonary artery to make sure there's no residual pulmonary stenosis. And these patients do fantastically well. But here's a patient, repaired tetralogy late, at age 15. She has recurrent atrial flutter, and she's referred to my friendly electrofiddlers because she's got recurrent atrial flutter. What's the problem with this chest x-ray? She's not referred to anybody in congenital heart disease. She's referred to the arrhythmias because that's what they think the problem is. But message number 2, if you have congenital heart disease and arrhythmias, you always look for a problem with the underlying hemodynamics. If you have a good repair of tetralogy, your heart size should not look big like this. The heart should be normal. So something is mucked up. It's not just the flutter. She has a hemodynamic problem. And what's that likely to be? Pulmonary regurgitation, of course, and often secondary tricuspid regurgitation. And that was the problem. And that's why she's having the arrhythmia problem. Look at this one, a 38-year-old man who has repair of tetralogy, and he refers himself. This is what his doctor wrote. Unfortunately, X was fixated on the RV enlargement and decreased function. I tried to explain it's reassuring that he hasn't developed pulmonary hypertension and that the RV can continue to function fairly well, as it doesn't have to generate significantly high pressures. But still, he's not feeling well. If he continues to have decreased RV function, he may progress ultimately to needing support with an RV assist device and potentially even a transplant. Well, this poor 38-year-old man read this and thought, yikes, I need a transplant. Maybe I should go for another opinion. And of course, what he needs is a pulmonary valve replacement before he's totally shot and he gets VT and sudden death. And that's exactly what we did. But unfortunately, these things we see written in the doctor's notes all the time. So I'd be a bit fixated on my RV function too if I had residual pulmonary regurgitation. And of course, this is what he has, and it's so easy to miss on clinical exam because the murmur is quiet, and it's easy to miss on echo. You don't really see all that pulmonary regurgitation there because it's laminar. But you look at the Doppler, forward flow, look at this rapid reversal of flow. That's severe pulmonary regurgitation. It comes down to baseline very rapidly, and we miss it on exam, and it's so easy to miss on the echocardiogram because you might not be looking for it, and it's not pulmonary stenosis, it's laminar flow. So beware, because these patients with these big RVs are at increased risk of VT and sudden death, and we need to replace the pulmonary valve before the RV is shot. Lastly, let's talk about late referral and mistakes in management. Here's a 64-year-old accountant that was referred by my friend Blair Erb in Montana, who got his hands on this patient sort of quite late in life. So he's 64, and he's been known to have congenital heart disease since 1969 on an Army physical. And he went into atrial fibrillation, and at that point he began at least annual follow-up with a cardiologist. He was paced, as you see, and he's now been on heart failure therapy for more than 10 years with an ejection fraction that's running around 30%. He had a cardiac catheterization every year for about 12 years. Pat, you talk about appropriate use criteria, a cardiac cath every year for about 12 years. For what? I'm not sure. But anyway, now with a heart size that's looking like this, and we're worried about him and he's more symptomatic, here's what his cath showed. Look at his pulmonary pressure. The wedge is 25 and the V wave is 41. Now he's referred after all these years. And look at this ventricle. It's shot. His ejection fraction perhaps is 30%. Look at the long axis. Look at this AV valve regurgitation. And here's the apex down format. So you can see here's this ventricle. Can anybody make the diagnosis here? Look at this severe AV valve regurgitation on the left side. It's torrential. Notice that this AV valve is the lowermost valve, and it's very gnarly looking and ugly, and there is torrential AV valve regurgitation. This diagnosis is congenitally-corrected transposition. This is when the right atrium enters the left ventricle, pumps to the pulmonary trunk, and the left atrium enters the right ventricle, which is the systemic ventricle pumping to the aorta. So this is why it's called congenitally-corrected transposition, because the blue blood and the red blood goes in the correct direction, but it goes through the wrong ventricle. So this is a right ventricle on this side, and this is a tricuspid valve, systemic valve, which leaks like a drain. And if this you identify on the echo, because the lowermost valve is the tricuspid valve, it always enters a right ventricle. Thank God for us on echo. That identifies the tricuspid valve and the right ventricle. And these patients will do well for a long period of time. This right ventricle is not doomed to fail until that tricuspid valve leaks. And look at this leak and that ventricle. If this was a mitral valve, you've heard a lot about this at this conference, and an LV, you would have sent that patient for surgery decades ago. But the assumption is because this is a right ventricle and TR, we'll just leave the patient. That's totally wrong. That is a serious mistake. These patients need the valve replaced before this systemic ventricle, the right ventricle, is shot, and they will do extremely well. We still replaced his valve. He got an ICD, but of course it's too late, as it would be if it were an LV. He's still got an EF of 25%, and he's still alive several years later, but the boat was missed, a serious mistake. He should have been referred early. Don't wait for the ventricle to fail. Replace the valve. Don't say the patient feels fine. The patient probably never moves their bottom. Put them on a treadmill, they'll poop out at 40%. Send the patient early for surgery, they'll do well. Our oldest is 86, and she still has an EF of 50%. Don't think the RV will fail. So I've covered cyanotic heart disease. Hopefully none of you will bleed your patients unless there's a very good reason. If the hemoglobin's very high and they're getting headache, poor concentration, hyperviscosity syndrome, leave them alone, don't bleed them, don't bronchoscope them when they get hemoptysis. Leave them alone. Usually the hemoptysis will settle. Failure to consider the diagnosis with exam and echo. Think about post-operative sequelae. Again, work with your local ACHD cardiologist. And remember, these patients really need our expert care. Don't send them late for surgery because they can live fantastically long and productive lives. I'll finish with the thought that success does not consider of never making mistakes, but in never making the same one a second time. Thanks very much for your attention.